So good evening, and welcome to the Coli Institute's Imaging Summit. This is something we started several years ago now. Is it 10 years? Oh, wow. Yeah. A decade ago, but I wasn't really, I've been there this long, so it can't possibly be true. And my course co-moderators are Justice Ehlers and Sunil Srivastava. You can see we have a fine faculty to really work us through all the imaging issues of retina for future reference for the fellows that are here. We do this in front of ASRS. We also have a retina summit in front of ARVO. Because of the pandemic, as you'd expect, we both have live audience, but we also have a very large virtual audience, so hi to the virtual audience. They're in the back there somewhere. So our objectives are shown here. I don't need to read them to you, but hopefully when you leave here, we'll give you practical imaging tips and tricks, as well as talk about some of the new things that are coming, some of the cool things in imaging, and we'll end with a few panel discussions on how we use imaging in our practice to better serve our patients. The activity is provided by Evolve Medical Education and iVista Medical Education, and we'd like to thank our sponsors, including Alcon, Apellis Pharmaceuticals, iPoint, Genentech, Regenexx Bio, Regeneron, and Zeiss. So these are our sponsors. If you haven't said hi to them in the exhibit area, please do at the break. Really, they're the lifeblood, which allows us to do these meetings basically for free for you. And really, please thank them. Plus, you can get some good information from them. So last year, we did this thing. It was kind of cool. Sunil had to explain to me what some of these things mean. But we're going to have a social media contest again this year. And the prizes are good. Noise-canceling Bose headphones, so good prizes. Unfortunately, the older doctors in the audience will not be able to win this because when I say you need to mention hashtag Coli Imaging Summit and tag iVista Medical Education, I have no idea what that means. So hopefully you guys do, because if you do that, tag us, go on social media, take pictures. The other thing is you need to be present to win, and we'll have 2 drawings at the end of the program. So good prizes. In terms of questions, so, for those in the audience, we have a small room, just really, ideally, just kind of call it out. This is a course. We want you to ask questions. We want you to test our knowledge. So please just walk up and talk and ask questions. For virtual attendees, though, there is a comment box below the screen, and you can send the comments to us. We will absolutely get it. I apologize if we don't get to every question that is asked from the virtual attendees, but we will try to go through all of them. At the end of the program, to get your CME credit, you'll get an email with instructions on how to get the CME credit for this. Obviously, you need to do a program evaluation and take the test to do that. So without further ado, we're going to start today with Yasha Modi. So Yasha was one of our fellows and now is attending here in New York. And he's going to talk about OCT imaging in age-related macular degeneration. Yasha.
All right. Thank you, guys. Always a pleasure being here at the summit. And, it's also nice to have this meeting in my hometown. So really, really happy to have you guys all here. We're going to be talking a little bit about OCT imaging in AMD and then its diagnostic and prognostic utility. These are my financial disclosures. And, frequently when we're in clinic, I think I oftentimes take a dummies approach to AMD. I want to know what clinical stage is this? Is there fluid? Is there no fluid? And do I inject or do I not? And maybe that's all we really need to know in 2022. But you know, one of the joys of being a fellow of Dan Martin is that we frequently always get story time during clinic. And it always starts with some lesson that we learn about macular degeneration.
High school? What is that picture from?
He looks exactly the same. He looks exactly the same.
I'm a child in that picture. So.
And so I always remember when he was talking about macular photocoagulation study and PDT for AMD. And I think I'm still waiting for that wisdom moment. And, you know, when I thought about when I started my training, it was 2011, and this is what the AMD classification looked like. So kind of similar to what we expect today. All of this was based on fundus photography and fluorescein angiography. But if you fast forward 11 years, it sort of looks similar in terms of non-exudative disease, but rather than talking about exudative disease, we're now talking about neovascular disease, and that's broken down further into non-exudative and exudative neovascular disease. As it pertains to advanced atrophic AMD, we now have increased granularity in the way in which we define this, whether there's complete or incomplete disruption of the RPE and the photoreceptors. And then somewhere off on the side where it's not really completely classified at this moment, we have non-neovascular AMD with subretinal fluid as well. And these advances were all driven by OCT and OCT angiography. And so the bread and butter of OCT is really providing an anatomic location to our choroidal neovascularization, and this helps us understand prognosis and potentially treatment burden in type 1, type 2, and type 3 neovascularization. But I wanted to focus on a couple of different scenarios. Scenario 1, fluid without neovascularization, and scenario 2, neovascularization without fluid. And in the first scenario, recognition can help us lower treatment burden, and in the second scenario, recognition can allow us to follow patients a little bit closer. And so for those in the audience, who would inject this patient? This is a patient you see in clinic. And any takers on this? All right, so we got a couple of takers for injections. And how about this one? Would anyone inject this one? And so, unfortunately, I just didn't give you guys enough information at this moment in time because these are two examples of non-neovascular AMD with subretinal fluid. And what I didn't show you was that the OCTA didn't have any evidence of neovascularization. And this was first described back in 2017 by Giuseppe Kerkis, who noticed that over the apex of a large pigment epithelial detachment, we can frequently have some subretinal fluid. And if you do an FA or an ICG, you won't find any corresponding leakage. And so some of the areas where we see this subretinal fluid is at the apex of the PED, as I showed you, between confluent drusen, also known as the drape sign, or at the base of a large pigment epithelial detachment. And of course, this needs to be verified by OCTA or an FA or ICG. So now we have clinical utility for OCT angiography in our clinic. And on the image on the left, you can see the flow overlay where there's no flow signal in that pigment epithelial detachment. And so there's a couple things that we learned from this. One, if we can identify this scenario, there's no need to treat with anti-VEGF. The caveat, however, is all these scenarios have higher rates of conversion to geographic atrophy. Now, this is something that we've heard a lot about. We're hearing a lot about this at meetings. This is the double layer sign or neovascular non-exudative disease. And I always throw credit to Phil Rosenfeld for this because he was one of their original describers of this scenario. And this is his case of both a ICG plaque and a corresponding OCTA image. And what he had looked at was he essentially looked at all patients that he thought had intermediate or advanced atrophic AMD. And what he had identified by OCT angiography is that 14% of these eyes, in fact, had neovascularization. And that if they had neovascular non-exudative disease, they were 15 times greater risk of developing exudation. And of course, we now know from the PROCON study, obviously the question is, should we start treating these eyes preventatively? And the answer to that is no, because when you look at rates of CNV conversion in neovascular non-exudative AMD, whether you're getting quarterly injections of aflibercept versus sham, they're more or less about the same. So the management of neovascular non-exudative AMD in 2022, no indication to inject until exudative, observe potentially, but maybe more frequently, and then consider home monitoring devices for these particular patients. So when we look about the landscape of AMD, it's an exciting time. This meeting is a really exciting one because we're covering 2 new FDA-approved treatments, including faricimab and the port delivery system. But those are what I call incremental gainers. The real sort of fascinating parts to me is advanced atrophic AMD, where you have 2 candidate therapies close to the finish line. And this is a C3 inhibitor and a C5 inhibitor. And so I'm not going to go into the details of the study design, but I wanted to go into the imaging criteria that allows you to get enrolled in the Derby and Oak study. So in order to get enrolled, you needed to have GA of at least 2.5 millimeters squared and no larger than 17.5 millimeters squares. And then the one caveat is this is all based on autofluorescence, and you had to have perilesional hyperautofluorescence to be enrolled. And if we looked at the top-line results at 12 months, of course that we know now that the results were split, but as we go out to 18 months, we start to see further divergence, and now this is in the hands of the FDA to decide whether or not we're going to have a GA treatment available. And of course, this begs the question now that we're all starting to ask, who should get this medication and how do you monitor progress? All studies use fundus autofluorescence, and now there's a push to understanding whether or not maybe OCTA would be better, OCT would be better. And should we start treating before atrophy coalesces into geographic atrophy? So when you take a look at this OCT, so we don't see any signs of clear GA, but what you see by that number 6 is you see this area of choroidal hypertransmission. So we think that this is nascent or incipient atrophy. And what's this threshold? This threshold has been better defined by the CAM classification, where on all the image on the left, the C-RORA, you have complete loss of the RPE and ellipsoid zone. And then in B, we have I-RORA, or incomplete loss of the RPE. And so this is important because it tells us a little bit about nascent atrophy as well as GA. So pegcetacoplan, this is a great drug. We're starting to see differentiating signals at 18 months. But if you notice, you're still having progression of your geographic atrophy in this treatment arm. So what are our possible solutions? Well, new drugs, that's kind of in the pipeline, but that's sort of out of the hands of retina specialists. But maybe we can consider using imaging to help us consider the possibility of treating earlier. But if we're going to consider that, we need to understand what anatomic features define earlier. So when we think about OCT biomarkers for prognosticating advanced AMD, there are some critical ones that I think we should all take home. One, incomplete RPE and outer retinal atrophy, or IRORA, hyperreflective foci, subretinal drusenoid deposits, also known formally as reticular pseudodrusen, and then OCT reflective drusen substructures. So I want to show you some examples of what this is. So we are all familiar with IRORA at this point, but the important point is that this finding precedes CRORA. And so here's another example of it in multimodal imaging. And the prognostic factor is that these individuals have a 5-fold greater risk of progressing to GA. And this was actually studied in a post-hoc analysis where over the course of 24 months, 90% of new IRORA lesions progressed over to CRORA. And here, sort of you can see the decay curve over time. So let's move on to hyperreflective foci. So this is that hyperpigmented change or hyperreflective change, I should say, in the outer retina. And the thought process here is that you have migrating degenerated RP granules, or outer segment debris, that's trying to move into a more oxygen-rich environment within the retina. And if you follow these patients over time from baseline to 6 months to 12 months to 16 months, you can see collapse of the RPE and that choroidal hypertransmission sign. And again, there's a 5-fold greater risk of progressing to GA over 2 years. This is subretinal drusenoid deposits, really sort of first articulated with the great clarity by Rick Spade to us. And what you see is a sort of reticular pattern on the near-infrared imaging here. And as we move from stage 1 to 2 to 3, you start to see that this is breaching over through the ellipsoid zone. And again, a 5-fold increased risk of progressing to GA. And sort of one of the nice interesting points is if you ever see type 3 neovascularization, you should always look for subretinal drusenoid deposits because they oftentimes coexist. Now this drusen is a pretty boring looking drusen. This is something that we see very commonly in clinic, but sometimes drusen can be not so boring. And what we're seeing here are changes in the reflective structure under the RPE and kind of within the drusen itself, whether it's hyperreflective or hyporeflective. The shape can be different. It can be conical or mixed. And this also portends a poor prognosis with an increased risk of progressing to GA. So then the question is, can we intervene early? Well, if you look at a post-hoc analysis from the GATHER1, what they noted was that the proportion of patients progressing from IRORA to CRORA was slowed in those receiving complement inhibition relative to sham. So I think what we've learned here is that OCT imaging has advanced us beyond the dummies approach to AMD. Understanding the nuances of fluid and neovascularization can result in diminished treatment burden and improve our understanding of risk. Imaging biomarkers help us identify risk progression to GA, and imperfect but essential treatments may be on the horizon, and exploration of imaging and patient selection is critical to maximize clinical benefit. So thank you so much for your time. I'm happy to entertain any questions.
So let's hold questions till after the next. We'll do 3 talks, and then we'll have some questions at that point. So the next speaker is my course co-director, Dr. Justice Ellers from Cole. He's going to talk about high-order OCT analysis and the use of AI to aid in clinical trial outcomes.
Thanks, Peter, and good evening to everybody. Thank you all for being here, and Yasha, thank you for the extra 2 minutes. I may need it. This actually dovetails well with what Yasha was discussing around ways that we can use our imaging to better understand markers for AMD. These are my financial disclosures. So the question really is, how can we use some of the new and emerging technologies like artificial intelligence to potentially augment our clinical trial approaches? And so I'm going to focus a little bit on dry AMD and a little bit on wet AMD. And the question often comes up, where can we use artificial intelligence? Well, specifically, we may be able to use it for automated detection of disease, for disease characterization, such as severity grading. Big data assimilation is something that's of great interest and to enhance our current platforms that we use. But specifically for this talk, I'm going to focus on how we can enable clinical trial endpoints that aren't otherwise possible, as well as providing opportunities for clinical trial enrichment. And particularly in certain disorders, such as dry AMD, that may move slowly, this may be a critical opportunity in understanding new therapeutics and how they affect things. So when we look at machine learning and AI and how it's helped us with OCT, there's a few things that are overall really exciting. One of which is looking into retinal layer assessment and compartmental visualization. Multiple groups have shown that using machine learning to augment our segmentation capacities has enhanced accuracy and overall repeatability. And when we look at some of the specific endpoints that we're going to discuss tonight, these just weren't possible because of how labor-intensive it was for readers to do at a traditional reading center with traditional image analysis methods. This is some of the work that was done by Sina Farsu and Glenn Jaffe at Duke, showing the traditional manual segmentation in the top right, as well as their traditional image analysis platform, DocTrap, and then their convolutional neural network, which shows improved and enhanced multi-layer segmentation. Multiple groups have been able to look at this, and we've done something similar at Cole, where we've used machine learning to allow us to look at some of the most interesting areas in the retina that can be very difficult to reliably segment. And the area I'm going to focus on for dry AMD is really in the outer retina and how we can better understand ellipsoid zone integrity. These are some of the outputs that we can get using machine learning augmented technology. We see here the relative thickness maps of the specific compartments of interest. So we see the segmented B scan in the top left. And then in the top right, we see the ellipsoid zone integrity map. Normal is green, which represents a thickness between the ellipsoid zone and the RP of approximately 40 microns. That area of pink is where there's total attenuation. We're not able to visualize the ellipsoid zone, and blue is in between where we see partial attenuation. We also see the sub-RP thickness map, which essentially is a Drusen distribution and volume map that we can see. And one of the exciting things with this type of technology is that you have multiple different metrics that can be exported to actually be used to look at risk, prognosis, as well as potentially therapeutic effect. So Yasha talked about some of the key biomarkers that have been validated by multiple different groups. And one of the things that we were really interested in is understanding, can these biomarkers also predict progression to AMD, and where should we consider them on the scale of value for us as we look at this from a clinical trial standpoint? So this is an example from a cohort that we looked at the Cleveland Clinic, and we see at baseline there's no evidence of geographic atrophy. We do see a fair amount of central ellipsoid zone loss here noted in pink. And 2 years later here, we see the geographic atrophy that develops, and you can almost imagine, if you look at the pink in the bottom right, that it looks very, very similar to where we saw the ellipsoid zone loss before. We see expansion of ellipsoid zone integrity loss over time as well on that map. This is an example of an eye that over 5 years didn't develop any signs of geographic atrophy. We see a reasonable amount of central subfield drusen burden noted there in green, but you see there's very minimal to no disruption of the ellipsoid zone in this eye. So in looking at these cohorts, we put it into a random forest model to predict which eyes go on within 2 years to develop geographic atrophy, and we were able to actually predict this with quite good accuracy, as you can see here. We wanted to look at various different features, and many of the ones that Yasha pointed out we also read, and they were all significantly associated with progression to GA, hyperreflective foci, complexity of drusen, pseudodrusen as well. But when you put them up against quantitative assessment of outer retinal integrity, they all kind of fell away based on the calculations and what we were able to see here, suggesting that along the lines of what we heard earlier, there may be a critical point earlier on that leads to the progression to geographic atrophy. So when we look at clinical trial enrichment, how could we potentially use this type of data to help us get the right patients in so that we understand if our therapies are working and potentially use shorter trials to identify this? So I'm going to talk a little bit about using this in emerging therapeutics. We presented on some of the data and we've looked at with 2 therapeutics, rizatriptan and lamipretide, and these both are novel therapies potentially targeting mitochondria, which is an interesting thought to then look at the ellipsoid zone, which is obviously a mitochondrial-rich zone within the retina. And in these early studies, they were actually looking in intermediate AMD and non-advanced geographic atrophy, which is sort of an oxymoron, to evaluate which eyes had the potential to improve in vision, something that was different than what we're seeing in the geographic atrophy trials where we're trying to slow it down. And in the rizatriptan trial, they showed that there was a reasonable number of patients that actually improved by 8 letters or more, which is quite a bit in eyes that have intermediate AMD. So one of the big questions was who improves and who doesn't. So when we looked at this, this was an example of an eye that was termed a responder. That was they gained 8 letters or more following rizatriptan therapy. And you can see that overall there's scattered drusen noted in the right. In the middle column though, there's minimal disruption of the ellipsoid zone, and this may represent essentially a critical point that patients can actually respond to the therapy if they have the structures intact. This is an example of a non-responder. You see near total ellipsoid zone wipeout, and even though there is some geographic atrophy that's present here in pink on the right, we see that there's subfoveal preservation of that as well. When we look at the differences between responders and non-responders, numerous quantitative metrics were able to be identified. And you could imagine if you know who is likely to respond and what's needed for those requirements, you could actually gate a clinical trial and use this as an inclusion criteria to get those patients in who have the best chance to respond. And more importantly, as we as clinicians try to figure out how to manage all these dry AMD patients, we could identify those patients who might benefit most from therapy and those patients who don't need therapy, and also potentially adjust our treatment, our follow-up intervals as well. So what about lamipretide? We did a similar analysis on their phase 1 trial and had very similar results, which showed that if you had ellipsoid zone loss, particularly within the central 1 to 2 millimeters, you really weren't likely to respond to the drug, whereas you can see, again, just a representative example from their trial, an 18-letter gain when you had that central 1 millimeter preservation. Now, this is in low luminance visual acuity, which was their primary endpoint that they were looking at. So other ways that we can also look with artificial intelligence is using more of a true machine learning black box assessment. What we saw before, that's all based on retinal layer segmentation, and so it's not a mystery of what's actually being marked and what's being evaluated. We've looked at some, and other groups have as well, ways to better characterize the outer retina, and these are some of the things that have potential, I think, for the future. One is being able to look at what we would term either at-risk EZ lesions or sick EZ. And this is a system that has been trained based on reader annotated and segmented images to essentially look for areas within the OCT cross-section that may be ellipsoid zone areas that are at risk. And so what you see here in the middle and the bottom is the grayscale confidence from the machine learning output of where it thinks the ellipsoid zone is not healthy and potentially could be an area where the geographic atrophy could spread. And so we're currently looking at whether or not this can identify both the directionality and potentially the velocity of GA progression. One of the other interesting possibilities, as Yasha alluded to, is almost all of the clinical trials have been based on fundus autofluorescence, but many of us don't have fundus autofluorescence in all of our offices. Some people don't have fundus autofluorescence at all. And so our decisions are going to likely be driven by OCT, and we need to be able to better understand what's happening at that level. And using machine learning technology, we can automatically evaluate what the geographic atrophy area is and the overall lesion, and the change over time as well to understand if this is someone who's progressing that we want to get them on therapy. Multiple studies have shown that using this type of technology, it actually correlates quite well with the fundus autofluorescence features as well. So I'm going to shift gears here and just run briefly through wet AMD as well. And this is where I think understanding fluid dynamics and compartmental volatility may have some interesting opportunity using machine learning technology. Similar to some of the layers that we now can analyze, fluid's a similar challenge when we look at what previous technologies were. They didn't allow us to do this in any sort of a labor satisfactory way. But now using machine learning, we can have really quite good performance. We see it now that's being looked at commercially, even home OCT monitoring, as well as in other research settings as well. When we look at this for evaluating wet AMD, the exciting thing is we can look at compartmental specific fluid dynamics, whether it's intraretinal fluid or subretinal fluid or sub-RPE fluid, and better understand the visit-to-visit variation that occurs for the patient and what implications that may have for their overall outcomes. We can get specific measurements around what the volumes are, what the regional locations are, and again, understand what's happening based on therapeutic change and therapeutic effect. We may also be able to identify specific new biomarkers, such as the retinal fluid index. And this is essentially the percentage of the retinal measurement that's made up of fluid. And this can essentially evaluate underlying atrophy that wasn't really able to be visualized at baseline, because you can subtract out that fluid and understand what amount of residual retinal tissue is there. So to show a couple of examples here where we've looked at this, in the Osprey clinical trial, we wanted to evaluate whether or not we could feasibly assess these fluid compartments and look at this over time. You see at baseline, after a single injection, you see near complete resolution of fluid, a small amount of residual intraretinal fluid that resolves over time. And doing this, we can then start to understand differences in therapeutics. We see here the brolucizumab arm compared to the aflibercept arm, not only in terms of the binary presence of fluid, but actually looking at percent of fluid volume that's reduced from baseline, and understanding a little bit more beyond just the binary presence or absence, how much volume's there, how much is that potentially affecting the patient. As we look at different dosing intervals, we can also look at this to better compare drugs in ways that we can't otherwise do without this type of technology. We can then also evaluate different areas, such as ellipsoid zone integrity, being able to show that, for example, this improves with therapy, even being able to look at the sub-RPE compartment, understanding how does CNV tissue change, PEDs change over time, and lastly, actually being able to quantify subretinal fibrosis. We've heard a lot about volatility over the last few years, and clinical trials have shown that CST variation results in poor visual acuity outcomes. And one of the questions is, when we look at these specific features, can we identify what's happening that may be driving it? We now can look at this as intraretinal fluid volatility, subretinal fluid volatility, and even subretinal material or hyperreflective material volatility, and can see that all of those affect visual acuity outcomes, suggesting that subretinal fluid, if it's dynamic, is not necessarily benign. We can see this when we look at subretinal fibrosis, that in fact, if you have an eye that has high volatility in subretinal fluid, there's a significant increase in subretinal fibrosis over time. And similarly, and this is an example here comparing low volatility to high volatility, when we look at this in terms of outer retinal integrity, this may be part of the key reasons why the visual acuity outcomes are different between eyes that fluctuate and eyes that don't. We see here that, again, once you start to identify high volatility, you see a drop in ellipsoid zone integrity, particularly with subretinal fluid and subretinal hyperreflective material. This is just an example here where they start at the same level at week 12, and then with extension out, progressive ellipsoid zone loss. So in conclusion, AI-based platforms and computation image analysis are likely to really play a major role for us in clinical trials and understanding new drugs. Additional research is really needed to better understand the overall role for these systems and how we look at these therapies, as well as how our regulatory bodies will look at some of these outputs. Overall, it's a really exciting time, and over the next few years, it'll be interesting to see how it affects our direct clinical practices. I want to thank my team at the Cleveland Clinic, and again, thank you all for being here tonight.
So the last speaker of this session on AMD is the chair of Cole Eye Institute, Dr. Dan Martin. Dan, you do not have the entire evening to discuss home OCT, but he's going to give us an update on home OCT.
Thank you, Peter. I serve as the as one of the two network chairs for the DRCR, and we sort of canvass the retina world, all the time looking for kind of new ideas, next trials. And one of the ones that has really attracted our attention as of late has been on home OCT. So that's what I'm going to talk about here, just the background and some of the trials that we're looking at in the DRCR. So take a look at these two graphs. These are two graphs from CAT. They're plots of the distribution of injection frequency over time. I think when we all started into the anti-VEGF treatment era, I think most of us assumed that if you generate a plot like that you'd have a steep bell-shaped curve. That's what I thought. And yet, not only this trial, but every other trial has really confirmed this. It's essentially flat. In other words, there's this incredible variability in the number of injections required to control disease activity in patients with neovascular AMD. The number of people who need 2 injections over a 2-year period is the same as the number of people who need 25 injections. And so how do you predict that? We've spent so much time in CAT trying to understand that. The reality is we can't find anything that predicts this. And so if you think about what we do with Treat and Extend, it's really, this is why we're trying to deal with the incredible variability. One way around that would be as if we had more frequent monitoring. If there was a daily assessment of disease activity, it should allow for personalized treatment that may improve outcomes and reduce treatment burden. So enter home OCT. You guys have heard some about this. It's a device, it's a desktop device is shown here. The patient self-images daily. Takes less than a minute. I'll show you in a second. And from Jeff Heyer's study, it's about 40 seconds. Basically, it's a 88 B scans spaced 30 microns apart, and it's a 3 by 3 millimeter field of view. And the data is automatically transmitted to the cloud. The patient actually doesn't see this. This is the flow. The retina specialist, we would identify a patient who would be a candidate for this. They refer them to the monitoring center for home OCT. The monitoring center then provides the unit and instructs the patient as to how to use it. The patient then images regularly, and those images are transmitted to the cloud. And then that is then made available to us to review the images and fluid dynamics, and also it allows us to adjust what we see and where we want to set those alarms. Basically, all this data that is compiled goes from a sequence of B scans to heat maps of fluid, and then the trajectories of fluid over time. And this is what the display panel currently looks like. It's an enormous amount of information. You'll see on the lower left and lower right, those are the heat maps. In the middle, you can pull up any 2 OCTs from any day and compare them side by side. You can have the overlay if you want to color code the fluid that's there. On the upper right-hand panel, you can set the alarms as to when you want to be alerted, as when there's been a 10 nanoliter increase in fluids. That's one thing that's going to take us a while to get used to. We're used to thinking in terms of fluid, in terms of vertical thickness. They're all thickness measurements, central subfield thickness or center point thickness. Here, the y-axis is nanoliters of fluid, and that's not something that naturally we correlate with how the patient is doing. Generally, as we've sort of looked into how we design our trials in the DRCR Retina Network, with the guidance from Natal and some of the studies that have been done, generally 10 nanoliters of fluid and below could be noise. Some of it may be real, some of it's not, but 10 nanoliters is the threshold we're going to use. If you look at what's published, there are a few papers, not a lot, but probably the best one is most recently Jeff Heyer's study. It's a prospective study of 15 patients, 23 eyes with neovascular AMD, in whom they performed daily imaging with home OCT for 3 months. This was a very highly experienced group. They had a mean of 27 injections per enrollment. There was a lot of fluid in these eyes. The primary objectives of the study was simply to evaluate the longitudinal imaging performance of a home OCT system, to understand the patient compliance and experience, and to begin to get a flavor of the disease dynamics and treatment response under standard of care treatment. There were 2,374 images during the course of that study, and you can see that the vast majority of them, 97%, were above what the manufacturer's signal quality index over the entire study population. This is an idea, just to give you a visual. The left would kind of be the minimal. The median in this study was 4.4, and on the right was 7.0. Basically, the quality of scans comes in close to SDOCT, maybe just slightly below that. Patients, the time to do it was 40 seconds, and what you'll see here is that it got shorter over time, and you can see also the standard deviation decreases over time, so the patient does learn how to do this. It doesn't take long, and it's as simple as, if any of you have used this thing, it couldn't be easier to use. Much to my surprise that the weekly scanning frequency didn't fall off over time. I expected that, you would expect that, but it didn't happen in this study, that the average number of days per week that the patients did image was 5.7. The monitoring center monitors this, and if there's no imaging for 2 consecutive days, they'll alert the patient and say, hey, what's going on? So they are certainly encouraged over time. Basically, all these images allows us to go from the snapshots that we get at 1 month or 2 months apart to having a daily assessment of this fluid. And then the AI images adds the heat maps and a much more detailed assessment. And then you have these trajectories over time, which theoretically could allow us to identify fluid recurrence earlier and treat earlier, or extend the interval between treatments. If you go back to the distribution I showed you, there is a proportion of patients, about 15%, that only need 3 or more injections in the first year of study. There's no way to pick those people out ahead of time. This would be a way to be able to identify those patients ahead of time. And again, when you start to look through these fluid trajectories, as we're starting to do in the DRCR, you find that they're really all over the map. There's a tremendous heterogeneity in what we see in these things. I find this information incredibly interesting. It's very seductive to want to look at this. It's really interesting stuff, and we're going to learn a lot from it. Here's a couple of things we might learn. First of all, just the speed with which the fluid resolves, and that if you intervene earlier, it resolves even faster. Again, you get a much, some of the ascension, some of the people have recurrence, it happens very quickly. Sometimes it happens very fast, and the response to anti-VEGF therapy can be very rapid, or in some cases, it can take a long time before it goes away. This is stuff that we don't know, because right now you're just looking at the dotted lines here and here, and as far as you know, that fluid never went away. The patient walks in, if you had just the 2 images where the dotted lines are, you don't know what happened in between. This is also these generate these cumulative fluid, fluid maps, or basic cumulative fluid thickness maps that show the location, so you can tell actually where the fluid started and the sort of how it extended. And then you can also, over time, you realize that sometimes it's not just the same spot that leaks. Sometimes the recurrences happen in a different location. When we begin to, as we've been thinking through this, and if others have been, both with Natal and also Jeff Heyer and a number of others have been thinking through this, there are a lot of interesting parameters to look at that we in the network are going to be very interesting and trying to provide data to look at all of these different parameters to see, are they predictive of, for example, the durability of treatment, the time between treatments, the disease-free interval. Does the first disease-free, fluid-free interval predict the second one? All kinds of great, nerdy stuff that I really like. So at the end of where we are right now, we're looking at this from the DRCR perspective. There are a lot of questions that are out there. Can we use this device to reduce visit and treatment burden? Basically, we need a randomized clinical trial, but basically no trial was currently planned. And the device is going to become available to us. It'll be approved as a device, but there won't be an efficacy trial required. So as we looked at this, we basically decided that we needed a feasibility study. And so we designed one and fully enrolled it. It's called Protocol AK. It was just 14 patients. They're followed over a 6-month period of time, newly diagnosed neovascular AMD. And the patients who are doing daily imaging, the doctors aren't seeing these images. It's not affecting their care. It's basically, this is just a setup trial to see, could we really do this as a larger trial? And the answer is very clear that we can. What we've learned already are the methods and logistics of image and data interpretation and the transfer from Natal, understand the willingness of patients to participate in and complete a program requiring home OCT monitoring, the ability of the clinic and the Natal staff to educate the patients, the basic understand fluid, and also we're going to look at what these images, how they're recorded, and we'll compare to the in-office OCT. To see how much agreement there is there. So what that's led to is protocol AO, and that's a home OCT versus treat and extend. It'll be 620 patients who will be with newly diagnosed neovascular AMD randomly assigned to treat and extend versus a home OCT guided treatment. The primary outcome will be mean change in visual acuity between randomization in 2 years. The primary objectives will be to compare the efficacy, safety, and burden of drug delivery and monitoring and the cost between the two groups over a 2-year period, to gain insight into as many questions about the retinal fluid dynamics during treatment, such as I mentioned, the duration of the first fluid-free interval. Does it predict subsequent intervals? We all assume that in treat and extend. We're looking for that interval. I'll tell you, I already know from some CAT data, it's not. The interval, even if it's 8 weeks, 8 weeks, 8 weeks, all of a sudden it's 12 weeks, the next time it's 4 weeks. It's highly variable, much more variable than people realize. And then these other, many other questions that we'll be looking at in this study. We're also going to look at, we realize that on the basis of previous studies, most patients will enter the trial with unilateral disease. If you look at CAT, Ivan, Harbor, all have 50 to 75, usually about 75% of people had unilateral disease. So that allows you the opportunity to look at the fellow eye, to do multimodal imaging, including OCTA, to look at the whole non-exudative neovascular AMD question. It was a hot question 3-4 years ago, but there's a lot of things out there still left to do. So in summary, home OCT is a promising new imaging platform that has the potential to personalize anti-VEGF treatment for neovascular AMD. I think it's going to substantially expand our understanding of retinal fluid dynamics during the anti-VEGF treatment. We have 2 protocols, AK, that's the feasibility study. It's already enrolled. We'll be announcing those results in the first quarter of 2023. And then protocol AO is the 620 patient randomized clinical trial. We've actually already started the certification and plan to start enrollment in the fourth quarter of 2022. Thank you very much.
So, Sunil, any questions from the audience?
Nope,
there?
none.
Virtual audience? Any questions? Let's open the floor to the audience here. So, Yasha, let's assume we have a anti-complement inhibitor in the future. How are you going to use imaging to convince patients to continue on a treatment? Let's say a patient who has, say, extrafoveal lesion. They're a year in, let's be optimistic, every other month treatment. How are you going to convince them to continue this every other month injection?
Yeah, I think it's hard, right? And we all have very different patients, and in the motivated and educated patient who understands that the time to GA progressing to the fovea is the time of viable vision. I think it's easy to show over time progressive GA lesions. And, I have a whole number of patients who I've been talking to about the possibility of treatments. And I would say the overwhelming majority of them are quite excited to start. And, when we talk about this, it's sort of a set it and forget it, in the sense that they don't really have to do much except just show up. And then it's kind of on us as retina specialists to sort of figure out, should we be thinking about running trials to treat patients earlier? A lot of the work that Justice was talking about, using maybe an aggregate in an AI algorithm of all of the qualitative elements of, that can predict atrophy a little bit sooner.
Go ahead, Jess.
Go ahead, Amani.
Yeah, I think our most motivated patients are going to be the second eye patients.
Sure.
They're going to be really excited to have something. And even if we can't show them a huge benefit, they'll be excited to enroll.
Yeah, and I think we've seen that in the clinical trial enrollments too, how motivated they are to get into the study. Dan, can I ask, the data is really intriguing around the fluid dynamics and the curves that you showed. We obviously have from the clinical trials that the CST fluctuations, and now we know fluid fluctuations matter. But what's really intriguing is that there's actually patients who are fluctuating and we aren't capturing it.
Exactly.
Do you think that we'll see that those are patients who may not do as well from a visual acuity standpoint, and that we're actually under-treating a reasonable amount in treat and extend?
It would make sense. We published, we did a combined study with Ivan, Kat and Ivan. We've looked at both persistent, in both intraretinal fluid and subretinal fluids, two separate papers, and we looked at the fluctuation, and the more fluctuation there was, the poorer they did, the greater the degree of subretinal fibrosis. You have to believe that, I mean, the more of these curves I've looked at all the ones from previous studies, and I've looked at the ones emerging in ours. It's fascinating to look at this stuff. You guys are going to like looking at it because a lot of stuff's happening in between your office visits that we don't know. I mean, way more than I ever imagined.
Yeah.
And I don't know how much of that's going to translate into something we should treat or not. Some of these eyes we may look and see a recurrence at 3 weeks. Are we going to treat then? Because I don't know that the pharmacy or is CMS going to let us do that?
Right.
It's really going to challenge a lot of what we do.
It's really interesting. I mean, for me, looking at the fluctuation, before I extend, I've now started to wonder more about bringing people back at a week and knowing, do they go dry, or are you just lulled into that 6-week interval or whatever it might be.
Hey Dan, there's a question. How do you incorporate the home OCT price into this whole discussion for your comparison groups?
So I have no idea what the price will be.
Okay.
And so people don't, but do know this, the price is not, so people aren't buying the home OCT device. It's a service that will be provided, and CMS should cover that service. So in terms of out-of-pocket expense, I mean, I don't know what the price is going to be, but I can't imagine it's going to be anything like out of the anti-VEGF cost.
Just a follow-up question on the volatility, right? We've sort of entered this sort of language of fluid compartmentalization and some fluid being better than other types of fluid, specifically subretinal fluid being better than intraretinal fluid. But Justice, that sort of goes a little bit contrary to what you were finding. So, what's your thoughts on allowing permissive subretinal fluid, even though you're still actively treating it? Have you changed your tune since you've sort of collected that data?
Well, the biggest thing, sort of what I was alluding to, is making sure it's not changing, and that in fact it is stable. Because you're exactly right, Yasha. When you look at numerous trials, subretinal fluid is associated with better outcomes. Part of it is that you also have dry eyes that have underlying atrophy, so their vision's worse, no matter what. But I think that we're going to know more about that over time on how to handle that. But I think it may change a little bit how we do it. It's a very small percentage of people who fluctuate, though.
Peter, our fellow has a question. Should we call him? Heidi, go ahead.
I mean, at the moment, I don't. It's sort of more of an academic interest, right? Because those prognostic factors don't necessarily confer an increased rate to exudation. Now, on the other hand, if I have a neovascular non-exudative AMD patient, those are patients who are getting on a 4C home device. I can actually implement an intervention that has clinical benefit, at least in my perspective, for that particular patient. But when it comes to these other features, until I have a drug that is potentially available to me, I'm not sure it's really impacting me other than just sort of like getting my brain working in a different way.
I hope you took a picture of that to upload on social media so you can try to win this prize.
All right, we're going to go on to the next section. It's my pleasure to introduce Dr. Mani Fauzi, who's going to be talking to us about imaging ischemia and diabetic retinopathy and new biomarkers. Mani?
Yeah, thank you very much. Really appreciate being here with everyone, and thanks to the co-I team for inviting me. And so today I'd like to tell you a little bit about OCT angiography and diabetic retinopathy, what we've been doing with it, and a new sort of ischemia biomarker that we've been working with. And so the difference between OCTA and fluorescein is pretty dramatic. In fluorescein, we get this wide-angle view of the whole retina, but in OCT, we're seeing a snippet of information in the middle of the retina. But an advantage of OCTA is that it's quantitative. We can quantify 3 layers of the capillaries in the macula, and it's unencumbered by leakage. So sometimes when we look at a late angiogram, half of the non-perfusion is already covered by leakage, but that doesn't happen in OCTA. So can we use that little snippet of 3x3 information in the macula to tell us about diabetes, about are the eyes referable? Is this a high-risk eye? And can we predict who's going on to develop complications, let's say, in 1 year? Those are the 2 things we try to do in this project. So what is clinically referable diabetic retinopathy? This is sort of defined as eyes that are more likely to progress in the next few months or a year or 2. So these are moderate to severe NPDR or higher severity of diabetes, and eyes with diabetic macular edema. These are patients that need to be seen right away by an ophthalmologist because they're going to be needing treatment. So this is our starting point. Here's sort of a cross-sectional data of 150 eyes that we imaged in our practice, and it's sort of across the spectrum. And of those, 71 were referable and 79 were non-referable. And here we wanted to use sort of the classic non-perfusion metrics that you get with OCTA, which is vessel density. We wanted to compare it to this new metric called geometric perfusion deficit. The nice thing about this geometric perfusion deficit, it defines a physiologic parameter that's sort of something we can understand. So any area of the retina that's 30 microns or more away from a blood vessel is considered to be ischemic. So not the entire sort of non-perfused area, but anything that's further away than 30 microns. It was defined by Fujimoto and Siu Chen when he was a postdoc. And basically they highlight all these areas in the macula and you can quantify them. And so this is what we found. If you look at the ROC results, it's kept coming back to the deep capillary plexus. It had the highest AOC, whether you looked at the geometric perfusion deficit with the FAZ included, if you exclude the FAZ, if you look at vessel density, if you look at vessel length density. For some reason, there was a robust indicator at the deep capillary plexus. So we wanted to take out the treated eyes and look at just the treatment-naive eyes. Here we had a lower number in the referable sample as expected. And again, it's the deep capillary plexus that kept coming up. So there's something very peculiar about the deep capillary plexus that makes it so predictive of eyes that are high risk for progression. So for the next question, we wanted to see, can we then use OCTA to predict complications? So here we wanted to look at moderate and severe NPDR without DME. So we wanted to see if these eyes could develop DME. And we wanted to look at a relatively short follow-up period of 1 year. And the literature tells us that the rate of progression in these eyes is anywhere from 12 to 56%. So some of these patients should be seen a lot sooner than others, but it's very hard for us to look at fluorescein angiography and know who's the patient that's going to have complications. So we wanted to see if OCTA can give us that information. Some of the things we know about progression, A1C, total glycemic load, but that only explains 11% in an epidemiologic population, but not to the patient sitting in your chair. So here we really want to see if OCTA can give us that. In this study, we wanted to look at eyes that were untreated, so treatment-naive eyes with moderate to severe NPDR, and we wanted to look at 1-year outcome. So they had a OCTA at baseline, and we wanted to see what happened to them clinically at 1 year. And the complications included PDR, vitreous hemorrhage, macular edema, or a treatment for any of those. So we started with 45 eyes at baseline, and only 15 developed complications. And as you can imagine, this is a 1-year follow-up, so it's very enriched population for complications. And if we look at how to do the GPD, we actually had a medical student who developed a fully automated method to extract the GPD so we didn't have to do it manually, and she did that on all the capillary layers. So our population was, like I said, 45 patients. there was an enrichment of males and those who did have complications. But interestingly, being severe NPDR at baseline was not associated with complications. So as you can see, you could have a moderately severe NPDR eye that develops complications and a severe one that doesn't. So just the severity of DR alone is not as predictive. And so here's an example of an eye that did not have complications, and highlighted in red are all the GPD areas. And this is an eye that developed complications. And again, there's a more prevalent areas of GPD. So again, we wanted to compare the classic density metrics to the GPD, and the accuracy again of the DCP turned out to be the highest. The next highest was the middle capillary plexus in this study. For GPD, similar thing. Deep capillary plexus had the highest predictive power, followed by the total retina and the middle capillary plexus. Next, we wanted to ask, is there sort of a threshold? Is there an ischemic threshold in an eye that can predict complications? And we looked at both the vessel density and the GPD, and it seemed that a sort of a deep capillary vessel density of 28.5 was predictive of complications. So if you had less density, and the average DCP density is about 40, 45. So this is when you've lost half of your deep capillaries, that's when you're at a very high risk for complications. And with the GPD, that was 12%. So what is it about the DCP? And here we had to sort of scratch our head and think outside the box. So Tim Kern has basically built his career and research on the importance of photoreceptors. So his view of diabetes is that it's a photoreceptor-driven disease. Oxidative stress in the photoreceptors is driving the vascular complications in the entire retina. And if you take mice that have no photoreceptors and make them diabetic, they don't get as bad of a retinopathy as if they had photoreceptors. So he's really done a lot of research in this area, and he's shown it in vivo and in vitro in the mice. Jeffrey Arden had the sort of the similar theory about how if you avoid dark adaptation, you could protect the retina from diabetic retinopathy. So dark adaptation is when the photoreceptors are most active. That's when oxidative stress is very high. And that was the impetus for some of the studies that were done in ROP for wearing goggles. And so the photoreceptors seem to be somewhere at a high oxidative stress in diabetes. And perhaps because the photoreceptors are so close to the deep capillaries, that area is where this oxidative damage and vascular loss interaction is happening. So you could imagine also if you lose your deep capillaries, that's very close to the photoreceptors, then you have a vicious cycle of perhaps ischemic photoreceptors in dark adaptation, because we know from Linsenmeyer's work is that photoreceptors, especially rods, are getting at least 10 to 15% of their oxygen in the dark from the deep capillaries. So the choroid is just not enough when they're highly metabolic. So there's a lot of sort of theoretical reasons why the deep capillaries could be the drivers, and it's one good reason to use your OCTA because this is not a layer that you'll see on fluorescein. So this sort of excites us about the utility of OCTA in the future. So it sounds like the deep capillaries can tell you about which eye is highly at risk for complications, and there may be a threshold for ischemia. Losing half of your deep capillaries seems to be not good for your eye. And it's the same idea with referable eyes. So if you have a lot of your deep capillaries already damaged, you may be at risk for complications. And it's very interesting to now start to look at this in larger data. And these two papers just came out, so you're welcome to see them. Thank you. Thank you so much for your attention.
We'll also do questions at the end of this section. It's my pleasure to again ask Yasha Modi to come up for the next talk, who's going to speak on alternative screening strategies for diabetic retinopathy. Yasha.
Great. Thank you so much. And Mani, that's just such amazing work. I find it so difficult to like identify the middle capillary plexus, and I think we need to talk a little bit about that because, that just should be incorporated into the way in which we currently get outputs, because all of our, commercial imaging is a superficial and deep capillary plexus. So yeah, it certainly would be an interesting thing to add in. Again, financial disclosures haven't changed. And diabetes by the numbers. Numbers are boring. And I frequently find myself recollecting numbers. I heard that 1 million people have so-and-so. But then I sort of say to myself, wait, was it 1 million or was it 10 million? Because maybe I'm forgetting. And I think that it's sort of hard to sometimes keep numbers straight, but they tell a story and they sort of provide perspective on the scope of the problem. But it turns out when you look at the simplified numbers in diabetes, actually Dr. Spade kind of brought this to my attention, that there's a wide range of prevalence of diabetes in the United States depending on what source you cite. So if you look at JAMA, there are about 10 million people with diabetes in the United States. If you look at the American Diabetes Association, they look at 37 million people. And the part of it is that they're looking at people who are not otherwise diagnosed yet. And the prevalence of diabetic retinopathy in the United States, it can be upwards of about 9 million people in the United States. And the prevalence of vision-threatening DR is about 1 million people. So if you think about 1 million people, let's sort of put this in context. If you have how many docs are there to screen those 37 million people? Well, in 2020, we had about 24,000 ophthalmologists, 2,400 retina specialists in the United States. So that doesn't include the optometry workforce. So if you just have ophthalmologists do all the work, what would be the number needed to screen 37 million people? Well, that'd be about 1,500 patients per year, or if we work 48 weeks in the year, that's about 6 patients a day. And each retina specialist treating vision-threatening DR is about 375 patients a year. And I bet you we all feel like we see about 375 patients a year of vision-threatening diabetic retinopathy. So then the question is, why are we so bad at accomplishing this? And these numbers assume normal distribution of ophthalmologists, retina specialists, and patients, but in reality, that's not our world. If you look at on the top, we have ophthalmologists. On the bottom, we have optometrists. And this is the distribution by county in the United States. And rural counties typically have a lower supply of eye care providers. And we are very, very far away from the bell curve. In fact, we really have 2 problems, which you can break down into the urban problem. This is diabetes disproportionately affecting racial and ethnic minorities. And then, on the other hand, we have the rural problem. The rural populations tend to be older, less insured, poor, less likely to receive guideline concordant care. So of course we know that teleretinal screening is a hugely valuable asset in order to screen our vulnerable patients, and this is currently being implemented around the country. And so this is an example of a patient who's asymptomatic. This is a patient from Houston that Christina Wang had sent to me, of a patient who was otherwise, believe it or not, asymptomatic and was screened through her Teleretina program. And so Teleretina detects diabetic retinopathy remarkably effectively. And if you compare that to in-clinic evaluations, there's very high concordance between DR staging, between Teleretina as well as clinical grades. This can also obviously be automated in various forms, both IDX and INUC. But when we look at diabetic macular edema using Teleretina, this is where we oftentimes fail. And I think part of the reason is that you're looking at a 2-dimensional photograph and then trying to infer whether or not somebody has diabetic macular edema. So integration of OCT obviously would be very valuable. We know that it's very easy to detect that on cross-sectional imaging, but it also drives up the cost. So we asked the question, what if we could use near-infrared imaging along with OCT to screen DME as well as DR? Well, you have the near-infrared image. This provides en-face visualization of the macula, but you also have the cross-sectional OCT image, which makes DME detection very obvious. So can near-infrared imaging detect DR severity? That's the real question here. And if so, can we use just one imaging modality, the near-infrared image as well as the cross-sectional OCT, to then improve our ability to detect simultaneously DR and DME detection? So for this proof of concept, we wanted to ask the question, can near-infrared imaging help us identify DR? So this is an example of a near-infrared Heidelberg image. And what you see is you see a whole host of hyporeflective foci here, which I've outlined. This is another patient, and here are the hyporeflective foci. And so these hyporeflective dots on near-infrared imaging identifies MAs, it identifies dot blot hemorrhages. So our hypothesis then is, does the number of hyporeflective spots correlate with disease severity? So we wanted to determine if these number of hyperreflective foci correlate with DR staging based on our clinical examination. And then number two, can we determine if we can reliably identify moderate NPDR or worse, essentially the threshold for referable disease by quantitating hyperreflective foci. So we created a pilot data set of 190 patients with diabetic retinopathy. We had 2 independent readers review this, and then we did a whole host of statistics on them. We excluded those with low-quality OCT images, and here's the sort of crux of this, is that all of us have looked at near-infrared imaging, and the signals can vary tremendously based on changes in the RPE. So we really only wanted to highlight those with hyperreflective foci with discrete margins in this particular analysis. And so we had even distributions of patients going from no diabetic retinopathy all the way to proliferative diabetic retinopathy, and we tried to get equal representations of different ethnicities, both black and white, in this data set. And when you look at the mean number of hyperreflective foci, it increases dramatically from mild to moderate to severe to proliferative. But the caveat is from moderate to proliferative, you end up sort of in this plateau effect. So really good at identifying those who have at least moderate disease, but maybe not so good at differentiating between those. And when we say, well, if we create a ROC curve for understanding when somebody has moderate or worse disease, that threshold was kind of right around 5 hyperreflective foci. So I submitted this. I was really proud of myself. And I got a comment from reviewer 1. And reviewer 1 says, Yasha, you're not doing an adequate examination to base DRSS scores on. I said, I wasn't doing DRSS scores. I was just looking at mild, moderate, severe. But what we always learn from the peer review process is if we can kind of like put our ego off to the side, we learn always something from the review process. And in this situation, the same reviewer said to me, the scoring system should have taken into account venous speeding, IRMA, NVE, NVD, which all would have been seen on the near-infrared imaging. So the pursuit of vascular anomalies is something that we're currently working on here. Here you can see an example of venous speeding in C. You can see neovascularization in D. And certainly these do show up on near-infrared imaging. And so we've just sort of gone through the data over the course of the last week or so. It turns out if you have any vascular abnormalities, then that basically identified moderate or worse disease in 100% of patients. And I'll spare you the boring statistical details, but suffice it to say that this improves our ability to detect severe and proliferative disease, which we were not able to previously do with just hyperreflective foci. So there are significant differences between no and mild NPDR and moderate and worse NPDR when just counting hyperreflective foci. And that hyperreflective foci are not ideal for differentiating more advanced stages of diabetic retinopathy, but it is reasonably good at identifying referable disease. And vascular abnormalities may help us identify higher grades of DR severity, including severe NPDR. So of course, this is a proof of concept. It needs validation studies. We're doing this on larger data sets. And then our next steps are to incorporate this into an AI algorithm. So thank you. I wanted to highlight actually Sachi Patel. She was actually one of our medical students, and she's been integral to this project. And we liked her so much that we kept her for residency. So she's now one of our PGY1 residents. Thanks so much.
Thanks, Yasha. So our last speaker for this section is going to be Dr. Prithvi Murthyunjaya, who's going to be speaking on multimodal imaging to diagnose the challenging fundus lesions. Prithvi.
Good evening. Thanks to the Cole faculty for letting me be part of this very interesting meeting, and I hope I can add some information. It dovetails nicely on Yasha's excellent talk. So we're going to talk a little bit about imaging used to detect suspicious lesions, and maybe a new twist that will add to this paradigm. Here are my disclosures. I'd like to acknowledge my co-authors, who are some of our residents and fellows, and Michael Yu, who received a VRS Foundation grant for some of this work being shown today. So even a uveitis specialist, Sunil, you paying attention? Might be able to tell that the image on the left is not such a bad appearing lesion, and the image on the right might be a little bit more concerning. And that might lead to a referral or further workup in that case. And these extremes are probably easier to identify from the clinical sense. Because what we're really trying to figure out is whether these lesions are malignant or not, and might they represent a small melanoma, for example. And why should we try to figure that out? Well, we know that up to 40% of patients with uveal melanoma may develop metastatic disease, and currently there's no therapy, even though one has only recently been FDA approved, that has been shown to longitudinally improve survival. And akin to the dermatology literature, early diagnosis and early treatment might have an impact on survival for our patients. So here are an array of lesions that we can see in our clinic. And when you see a fundus lesion like this, you often ask yourself, is this a nevus? Is this a melanoma or something different? How do you know that for certain? And if you are wrong, will that inaccuracy in diagnosis harm the patient? So we use multimodal imaging in our tumor clinics to be able to get as much information as we can about these lesions and help us to decide some of those answers. When we think about multimodal imaging, there are photography, OCT, which is very important for us, ultrasound traditionally looking at thickness, but also now autofluorescence and various angiography methods to look at vascular changes within the lesion. So there are 4 key questions that I have when I look at a lesion, and I want to share my thoughts on those with you. So the first is, where is the lesion? What layer of the eye are we talking about? So when we talk about the primary pathology, first we have to think of what lesions are located in which parts of the back of the eye. So when we think about vitreous disease, we think about lymphoma, a patient may have vitritis. If it's in the retina, we think of retinoblastoma, astrocytic hamartomas, combined hamartomas, and lymphomatous lesions. In the RPE, we classically think of chirpy lesions. And in the choroid, nevus, most commonly melanoma, but also metastases, lymphomas, hemangiomas, and not much happens that's really bad in the sclera. So here's an example of a patient that has this white mulberry type appearance, the bright white hyperautofluorescence, and then the OCT tells us that this lesion is clearly within the retina, within the inner retina, and has a moth-eaten appearance that's been described. That's pretty classic for an astrocytic hamartoma type lesion. So the combination of these modalities has helped us make that diagnosis. This is a 60-year-old with blurry vision and gait instability who presents with vision changes, and we can see the lesions as they're cut through demonstrate deposition in the sub-RPE space, but definitely not in the choroid. And this is a patient with vitreoretinal lymphoma, versus patients that may have undulation of the RPE, similar white appearance, but no separation between the RPE and Brooks with choroidal thickening. So now this lesion's not in the sub-RPE space, but in the choroidal space. So this would be an example of an OCT of a patient with a choroidal lymphoma. The second question is, are there patterns that you need to recognize? So here's an OCT of a typical choroidal nevus. We see a couple of things. One is the compaction of the choriocapillaris. We can see variability of thickening and also surface alterations, like in this case, small drusenoid elevations and some intraretinal fluid. Why do we get compaction of the choriocapillaris? On the left is a normal choriocapillaris that shows the large vessels, but in a patient with a melanoma, it's kind of the deeper layers that start to proliferate and push that choriocapillaris up towards the RPE Brooks complex, and it causes that compaction. This is a different patient, so 2150 acuity with the exudative retinal detachment. The OCT shows not a smooth, but rather a lumpy choroidal infiltration. On multimodal imaging, we can still see that pattern that has very thick choroid, but also abundant subretinal fluid, and this is a patient with a metastatic non-small cell lung cancer lesion. And it's that lumpy, bumpy pattern that's been described that tells us that this is consistent with a choroidal metastasis. And the morphology overall aids in the diagnosis. So a pigmented lesion like this with a smooth dome-shaped elevation with subretinal fluid, consistent with a choroidal melanoma, an amelanotic lesion with this elevation that's lumpy, bumpy, consistent with a choroidal metastasis. So that pattern really does help us. Third, are there secondary effects on the retina? So here, OCT identifies some of these effects that can include fluid, thickening, RPE alteration, but most important, the presence of subretinal fluid or subretinal deposits. That may give an indication about the chronicity, the severity, and the activity of these lesions based on how you put that together. And finally, can multimodal imaging help to confirm your clinical suspicion? Here's a case of a 78-year-old patient who was sent in with a pigmented melanoma mass, and we were trying to decide, is this a melanoma? It's pigmented, it's round. Some variability in pigmentation can be seen. When we look at the Optos autofluorescence, it has kind of an iso autofluorescent picture. It's not really bright, so we're not seeing a lot of lipofuscin on the surface. It's domed and elevated, and it has low reflectivity, but really, really low internal reflectivity. It's not kind of variable in its appearance. On fluorescein, we see some early blockage and late pooling, but it's the OCT that helps to put it all together. When we cut through this peripherally, we can see that this is an elevated, domed elevation of the pigment epithelium. So this was actually a hemorrhagic pigment epithelial detachment. So an ectopic disciform lesion that, when you observe, actually doesn't get bigger, it gets smaller, which is not what cancer does. So on follow-up, we can see the double-humped retinal pigment epithelial elevation in this case. So some of the questions are, can imaging replace the clinical exam? Are we not required anymore as clinicians? And probably the answer is no for now, but I think it depends on what we want imaging to do. If we want expert level diagnosis, we want high accuracy, very low false positives, and we want this to guide our treatment. How do we want to treat the patient? But in a screening population, which is what we were talking about in the previous talk, we want the screening to be accurate. We want to have an acceptable amount of false positives, but we want it to guide referral. We've all heard of mnemonics that have been used to identify clinical features that may be suspicious, that would allow risks to be quantified for risk of growth and metastases. When we look at these various risk factors, it comes down to, when do I refer the patient? So the majority of patients that are being screened are by optometrists, general ophthalmologists. There's limited equipment and expertise to use all of these imaging modalities in every office out there. In the UK, which has a nationalized system for referral for these melanocytic lesions, they developed the MOLES algorithm at Moorfields, where they looked at a few clinical features that came in with the patient in terms of a photograph and in their chart, which was the mushroom-shaped appearance of these lesions, orange pigment, a larger tumor size, history of enlargement, and subretinal fluid. They scored each of these factors and validated that if it was a composite score of greater than 3, then this was a probable melanoma that warranted referral. If we look at these risk factors and we want to see what can be confirmed by imaging, we think of thickness by ultrasound, lipofuscin by autofluorescence, subretinal fluid by OCT, and location, drusen presence, color by photographs. And all of these three, I'd argue, could be done by one, if not two machines in your clinic currently. But what we don't have always access to is expertise and availability of ultrasound. So how do we know if something is thick or not just by a two-dimensional image? So we wanted to explore this, and we looked at OptiMap images, in which it's a pseudo-color photograph that's a composite of a red and green laser image. The red channel goes down to 633 nanometers into the choroid, whereas the green channel is at 488, which is to be at the level of the RPE. So what we wanted to look at is a series of patients. So these are patients that have melanocytic lesions of different thicknesses. If we look at the red channel that's going deep into the choroid, that's fine, but the green channel looks a little different on each of these. So if we highlight the lesions here, if it's a flat lesion, it's kind of hypo-intense or iso-intense to the surrounding. If it's a little bit thicker, slightly hyper-intense, and if it was more thick, it's more convincingly hyper-intense to the surrounding as well. And there have been some digital imaging studies that have noted that melanomas have a distinct brightness on this green channel. Our hypothesis was that the green channel correlates with thickness, but it doesn't really tell us that it's malignant or not, and that melanomas may only appear more intense because they tend to be thicker, not because they're necessarily more malignant. So what we looked at, and this is the work by Michael Yu, is that if we looked at the red channel and then an area around that red channel of non-involved tissue, but then also on green channel, and then used quantification methods, what we found was that there is a difference between the area that's measured within the lesion and the area around the lesion, and we called that the pixel intensity difference. So we looked at this on the green channel in Optos and correlated the thickness to ultrasound measurements in about 140 eyes. Majority of these were smaller lesions, and a majority of them were nevi. And we could see that based on these various size criteria, there is a difference in this measured pixel intensity difference. So if we look at our plot, we can see that this is our regression line of 0.844. These were the melanomas clinically diagnosed, and there were some patients that had halo nevi or dense drusen on the surface that seems to throw off our model. And if we left those out for now, we did see an improvement in the overall regression line. So if we then take a pixel intensity difference of 5 and then looked at that as a threshold to detection of tumors that were 2 millimeters or higher, which you remember is one of these risk factors that we look for greater than 2 millimeters. And if we look at all the lesions, high sensitivity and a specificity of 70%, if we exclude the halo nevi and the drusen, then we bump up our specificity quite nicely. So let's take an example, a patient with a lesion that's growing over time. We can see it enlarging on the photographs. Here's the red channel, here's the green channel, and then we looked at our pixel intensity differences, went back and plotted it onto the graph that we have, and then we came up with what we thought were the corresponding thickness measurements. Now, if we look at the estimated thickness measurements and then the actual ultrasound thickness measurements, we see that we're within about 10% of the actual lesion height. So the color photos might replace an ultrasound? Probably not. Ultrasound, don't throw your ultrasound away yet. But the lesion thickness correlated with this green channel hyperintensity, and it's, again, independent of malignancy status of the lesion. And the 2D ultra-wide field images can be used in most cases to reliably estimate lesion thickness for the sake of referral and may have a role in screening. So key tips: know the layer of the lesion, recognize the pattern of the imaging, determine secondary effects on the retina that might give you a sense of activity, and then utilize multimodal imaging to make that final diagnosis. So what is the future? It's not what we see, maybe it's what we don't see, and it could be what the computer can see for us. So there's a potential for artificial intelligence applications with all this information that we're putting in, and we recently were part of a white paper that's looking at this as part of the collaborative community. So thank you very much for your attention and the invitation.
Thanks, Prithvi. We're going to actually go ahead and go on to the next section. We'll do all the questions during our panel. So again, I'll ask Dr. Mani Fauzi to come up for her next talk, which will be on illuminating the white dot syndromes.
Thanks a lot, Justice. So I think the white dots for me personally were some of the hardest diagnoses to make in clinic when I was a resident and junior faculty, and I think it didn't hit me until I worked with Lee Jample at Northwestern how much I was missing. And I started to wonder, because he taught me. But I started to wonder why it's so hard to think about the white dots. Not half of it is that the names keep changing, I guess, but really it's that we're taught to look at them in color photography. And if you think about the white dots on color photography, there's just a lot of problems. We're not gas, we're all not gas, so we're really not good at doing biomicroscopy anymore. They're not really white. Half of them are gray or shades of gray. And really figuring them out on color photography is really hard. So can you imagine having the patient in the exam chair and trying to see these white dots? So I think the problem is that we're taught to look at them at color photography. They're maybe subtle. They're not really white. They're mostly shades of gray. And some of the names are actually antiquated and wrong. So the more we image, the more we know that multifocal choroiditis doesn't have much of choroidal involvement. The dots and MEWDS are mainly spots and not really dots, so there's a lot wrong with these white dots. And I would argue that if you just had one test to do, maybe all you want is an OCT, and maybe that'll save you a lot of anxiety when you're faced with these patients. And so these are the four or so lesions that we'll talk about today, and hopefully I'll convince you that with OCT, you don't have to be as nervous about these white dots and not struggle with them in the clinic. So just get the OCT first and just kind of cheat the answer before you talk to the patient. And so the first one we'll talk about is acute macular neuropathy. It was described in the 70s, and it's really precipitated by a lot of the vasculogenic drugs, so caffeine, adrenaline for allergies, so some of these OCP, so there was a lot of vascular sort of risk factors to this disease. And I think near infrared, in this disease, I think near infrared clinches the diagnosis most reliably because you could see that petaloid pattern very, very clearly on near infrared. So this is one of the first patients we had in our paper, and this patient came within hours. So if you catch the patient within hours of the symptoms, what you see is a lesion at the level of the outer plexiform layer. So that's where the lesion starts. You bring them in a few days later, it's a different story because that outer plexiform lesion disappears and the lesion is now at the level of the photoreceptors. Bring them in a few more days later and it's totally changed because everything in the outer plexiform has disappeared and the lesion may even get bigger. So if you look at the infrared image, the shape has changed and it's dived into the interdigitation zone. And the progression is just fascinating and it's very reliable. Most of the time we catch patients when they're at the level of the photoreceptors. That's when the infrared lesion is brightest, and that's where most patients come to clinic. And that was sort of the first paper we wrote on this. And I thought about what would explain that progression, and at the time we didn't have OCTA, but I thought because the injury starts at the level of the outer plexiform, in my mind, it had to be a deep capillary lesion, just the way it dived down those plexiform. But we had to wait 10 years or so to confirm that. So I described this to the residents at Northwestern, and then a week later, one of the residents comes to me. They say, oh, we think we caught another one. We think we saw an AMN patient. And they had that sort of faint infrared lesion. But the OCT showed that the lesion was way higher than we'd written. I said, oh, maybe this is a new variant. It's just going to keep diving down the retina all the way to the photoreceptors. But lo and behold, this lesion did not budge. It basically stayed in the inner nuclear layer. And over time, what happened is the inner nuclear layer just thinned out, and the secondary changes in the outer retina are just probably distortion of the Henle's nerve fiber layer. So there is no involvement of the Henle or plexiform in this disease. It just stays smack dab in the inner nuclear layer, and that's PAM. So at the time, we kind of thought it may be a variant of AMN, but now we know that PAM is very prevalent. If you have a patient with vein occlusion, arterial occlusion, any type of vascular injury, you'll have PAM, but very rarely will you see AMN in sort of a walking, talking, healthy patient. And so the two levels of ischemia is basically the middle capillary plexus and the deep capillary plexus, and we finally were able to do this when we had the OCTA to confirm our suspicion. So this is more of a vascular disease, if you will, the two variants of it. So this is a different disease. This is a 30-year-old. Most of the white dots are in females, so it seems a sort of a predilection. So this is a 30-year-old white female who has sudden decreased vision in her right eye. And the thing that I want to draw your attention to is this granular fovea. So if you see nothing else in this disease, it's this granular fovea. Because the spots will go away, but the granular fovea will live on for years after the patient's healed and completely resolved, and you can sort of discover this and sort of ask the patient if they had ever had symptoms in the past, and maybe you'll uncover it. But this stays on. The spots themselves can be seen on autofluorescence if the photoreceptors are involved. If you catch a healthy, a good autofluorescence before you do other imaging. The other characteristic is this wreath-like hyperfluorescence. And on ICG, if you wait till 20 or 30 minutes, you'll catch all the spots, and you'll see a lot of them on late ICGA. But you can't catch them in early ICGA. You really have to wait 20 or 30 minutes to catch them. And this is the multiple evanescent white dot syndrome. But they're not really dots. They're mostly spots. So even Jampel made a mistake here when he called them dots, huh? So he won't admit it though. But there's dots and there's spots. So here on OCT, you'll be able to tell them apart. So this, in the middle, you have that volcano-like eruption from the photoreceptors. That's a dot. And then if you look over on the right side, that's an area where the photoreceptors are absent, and that's a spot. So this is sort of the dots and spots that you'll hear about, and patients can have dots on spots, dots alone, and spots. But the fascinating thing about this entity is that it resolves very dramatically, very quickly. So here's a 2100 patient. 2 weeks later, they're 20/30. They may still have some symptoms with sort of scotomata, but within another 2 weeks, everything resolves and the photoreceptors recover. If you do an en face, you'll be able to watch these spots as they heal. And there's totally it completely resolves, and the photoreceptors are completely healed at the end. But if you want to really sort of find evidence of past episodes, you want to look for these granular fovea, which is likely at the level of the RPE. The next white dot looks a little different. This is another female with a central scotoma. It's more apparent, but if you look at the OCT, the entire lesion is located between the RPE and Brooks membrane. You can see Brooks membrane clearly below the lesion, and then there's hyperreflective material spilling into the outer retina. You can sometimes see some subretinal fluid, but the majority of the lesion is in the sub-RPE space. And then if you do a fluorescein angiogram, you'll see leakage. There'll be multiple lesions. So this is PIC. But here, the first question we ask ourselves is this just inflammatory, or is it also neovascularization? So here I find OCTA very helpful. If you look at these two lesions, they're both leaking, but only one of them has neovascularization within it. So that helps you sort of guide the therapy. Some people just start with anti-VEGF anyway, but this is sort of a way to tell. And as you treat those patients, something very interesting can happen. They can end up with this outer retinal excavation, and sometimes you see it years later and you don't know about the episode. And so this is something that's left over from sort of weakening of the choroid in these eyes. So here's another variant of this. The telltale sign is this ring of multifocal hyperpigmented lesions, this Schlegel line in the equatorial area, and that tells you that this is probably multifocal choroiditis. So the most active lesion is where the arrow is, but it's not in the fovea, and for some reason this patient had hand motion vision that was unexplained. So this we had to scratch our heads over this patient. And if you look, none of the lesions are in the fovea, and none of them really explain this hand motion vision. So here's that extrafoveal active lesion with the hyperreflective material. But if you look closely at the photoreceptors, they're not doing very well, even in the fovea. So there's a ring of loss of photoreceptors or disruption of the photoreceptors that you could see on the infrared surrounding that multifocal lesion. And that could be sort of like an immune ring of photoreceptor damage that can happen in some of these eyes. And some of them will resolve spontaneously, like in this patient who basically was lost to follow for 4 weeks before I could work her up and came back 2020 a few months later. So some of them will resolve spontaneously, but sometimes they don't. And we don't know why, and it's a fascinating problem. So we now think of multifocal and PIC as a spectrum of disease. I think OCTA is very helpful to detect neovascularization. And think of those eyes with zonal photoreceptor loss, and you may want to treat them more aggressively and earlier, as they may be associated with vision loss. So this is the last entity, a 42-year-old woman again with spots in her vision. But if you look in the other eye, she also has one spot. Here is hypofluorescent early and then leaking late. And if you could look carefully in the macula, some of the lesions are already starting to pigment. So some of these lesions are older than others. And then ICG early here in this entity will show you hypofluorescence because the lesions are at the level of the anterior choroid. So this is the classic OCT. You have sort of a block of hyperreflectivity that goes from the plexiform all the way down to the photoreceptors at the same time, simultaneously, not sequentially, as in AMN. And you have some involvement of the anterior choroid. So this is acute lesions of AMPPE. And if you wait a while, they start to heal as well. And so this is the acute lesion involving sort of plexiform down to photoreceptors. And as they start to resolve, there's hyperproliferation at the RPE, but resolution of the other changes. So one of the most fascinating patients I saw was this patient here who had total wipeout of her photoreceptors in the fovea with hyperproliferation of the RPE and hyperautofluorescence. And she was very frustrated, 20/40 vision, but very frustrated because the vision was not good. And I really didn't want to discourage her. And I said, no, let's just watch you and see what happens. And this is the most amazing thing. Her photoreceptors started to come back to life. And so if I had to bet when I first saw her without an external limiting membrane, I would have said this fovea is totally gone. But there's something fascinating about this disease. And here's her other eye, hyperproliferation of the RPE. If we see this in AMD or in Placoid, we think this fovea is gone. But over time in this entity, amazingly, the ELM comes back and the photoreceptors come back. And we've looked at all our patients, and it happens. It takes a very long time, 10 months, 6 months, a very long time, but it's amazing. You get recovery of all the outer retinal layers if you persist with those patients. And we know that the choriocapillaris is probably the primary site of involvement in this disease. So if you look at areas where the inner retina is not involved, the choriocapillaris will be affected. So it starts probably at the level of the choriocapillaris. So the difference between AMPPE and MEWDS is very interesting. This is a very nice paper by Alain Godric, which taught me a lot. So if you think of AMPPE as a choriocapillaris disease, you see it very early on the ICG, the hypofluorescence, because it's non-perfusion. Compare that to MEWDS, where you have to wait 30 minutes. So his hypothesis is that the lesion in MEWDS causes some level of dysfunction of the RPE, and RPE normally picks up the ICG from the choriocapillaris, and because of that dysfunction, it is unable to do this uptake, and that's why you have to wait 30 minutes for this active process to happen in the entire RPE except in the areas with MEWDS. So that's the sort of interesting tidbit I learned. The other variant of this sort of placoid lesion is that you have to always think about masqueraders. So syphilitic placoid lesions can look like this, as well as serpiginous TB can present like this. So you have to keep those in the back of your mind when you see some of those patients. The other worrying thing about this is headache. So if you have a patient with headache and AMPPE, you have to think about CNS vasculitis. These patients need to be neuroimaged, maybe admitted, get neurology involved, because they can have serious CNS vasculitis. The other thing that worried us about this patient is the extent of involvement of the periphery, and you want to think about relentless placoid, which is another of those placoid entities where the lesions just keep coming and extending into the periphery, and you get crops after crops. And if you've ruled out TB and syphilis, that's this variant where you actually need to immunosuppress these patients. So in our hands, this patient actually, all the lesions resolved in one fell swoop, and he never developed any additional episodes. It was just a severe case of AMPPE. So again, rule out TB or syphilis in these eyes. There's a remarkable level of recovery of the external limiting membrane and the photoreceptors. If they have headaches, screen them for CNS disease. And just in summary, if you think about the level of involvement, it'll help you a lot with these white dots. So for MEWDS and PAM and AMN, these are really self-resolving diseases or vascular diseases, so immunosuppression is never indicated. However, in AMPPE, sometimes when the lesions are severe, you might consider steroids. In multifocal PIC that recur a lot, I send them to Deborah Goldstein in our practice. And of course, in relentless placoid, if the crops and you've ruled out infectious etiology, you almost always have to immunosuppress them. And so think about the level of pathology, and I think it'll simplify how you understand these diseases and hopefully you won't be as disturbed as I was when I was a resident. Thank you for your attention.
Thanks, Amani. And our last talk for this section is going to be by Sumit Sharma, who will talk to us about imaging outcomes in uveitis. Sumit?
Great, thank you. So my financial disclosures. And so uveitis, as we just heard, can be very challenging, and overall the outcomes are not great. We know that severe vision loss occurs in a quarter to a third of our patients, and our best therapeutics are only okay. We only have about a 2/3 of a chance of controlling our patients, and it's often because we don't recognize the disease fast enough, or we have a tough time identifying who really warrants aggressive therapies, and our current therapies aren't great. And part of the problem stems from the fact that we use these older ordinal scales to quantify or to classify the degree of inflammation, and they're not great at showing the difference between different stages or at quantifying or really giving us a continuous measure of inflammation. So if we look at the kappa for inter-observer or even intra-observer correlation between these grades, it's not great. At best, you get a kappa score of 0.5 to 0.6, but it can be even lower if you're trying to look at the same grade. So our goal over the last few years has been to develop quantitative measures of inflammation and to use software-based metrics that look at and develop a continuous scale for inflammation, and to make these a reliable and reproducible measures, and use imaging devices that we already have access to and that everyone has access to in their offices, and to be able to use these devices then to automatically give you a measure and then use them in clinical trials and in clinical practice. So this is an example of our software running, looking at, on the left, this is an OCT of the anterior chamber. At the very top, you have the cornea, and the hyperreflective dots below it are cells in the anterior chamber. And on the right, the software is actually going through and quantifying the number of cells that are seen and giving you a fluid density, or your cells per millimeter cubed. And this is a very inflamed eye. And we've shown and published on this before that it correlates highly with your clinical exam. You still see cells in uveitic eyes even when they're called quiet at grade 0 or trace cell. And in animal models, we've actually proven that the cells identified by OCT are inflammatory cells, and the counts actually correlate. So next, we needed to show that these are reproducible and reliable. So we took a study of 643 eyes of 230 patients, and we imaged the same patient either with the same imager, so the same imager, same photographer imaging the patient twice, 5 minutes apart, or two different photographers imaging the patients 5 minutes apart. And we looked at how they did, and we find that for both the same imager as well as two different imagers, the correlation between the number of cells that are counted are very, very high. So for anterior cell imaging, we can give very high reliability data, and we can see that the differences between the different grades are very different. So for the sun grades of 0, half, or 1, you actually see cells in almost all of these patients. So even though we're saying they're inactive, we're still seeing cells there, and we're not very good at differentiating between those grades. But when you start getting between 1 to 2 plus, the difference there is much smaller than the difference between 2 to 3 plus, and the difference between 3 to 4 plus is even greater. So what we really need is a little bit more granularity, and a continuous scale like this would give us that granularity. And then looking at responsiveness, this is a experiment that we did in patients who are undergoing cataract surgery, and we see inflammation post-operatively, and we wanted to look and see how the inflammation post-op correlates to the cell density that's seen, and how it correlates to either a uveitis specialist grading them or a cataract specialist, or the cataract surgeon grading them. And what we see is, yes, the number of cells in that first column, the cell density post-op day 0 is the highest, and then drops as time goes on. But the correlations aren't great, even comparing between a uveitis specialist, or there's some correlation, but then when you look at the cataract surgeon, there's absolutely zero correlation in how they graded the AC cells. So now we have a robust and fast tool that can measure and quantify the AC inflammation, and we can monitor patients for inflammation over time in both cataract surgery patients. We've looked at it in screening in pediatric patients, and also in the patients who present now. We have it in an optometrist office, and looking at it in patients who present with a red eye to quantify the degree of inflammation. And this is also now being used in some clinical trials as an OCT-based outcome measure of the degree of inflammation. But what about the posterior segment? So there's been a number of groups that have shown how you can use OCT to quantify vitreous haze, but we don't feel that it's a great measure, and the reliability isn't that great. But our work, including some of the stuff that we've talked about before on retinal vascular leakage and wide field FA and OCT segmentation and fluid calculation, can show you the degree of leakage in eyes over time. So this is 2 different patients with different amounts of inflammation in their eyes, and the red is an overlay over top where the machine is calculating out the amount of leakage. And when we compare active versus inactive eyes, even though these patients have similar clinical and OCT vitreous A scores and similar OCT central retinal thickness, the retinal leakage area significantly is different between active versus inactive eyes. Well, how does this correlate, and how reliable is this? Well, we compared patients using the automated algorithm versus manual correction by 2 separate readers. We found actually pretty high interclass correlations, not as high as for the anterior segment, but still anywhere between 0.8 and 0.9 between the manual segmentation versus the automated. And then switching gears, looking at the intraretinal fluid, some of the stuff about that Dan showed in terms of intraretinal fluid volumes and similar things that we're looking here. Pre and post treatment, seeing improvements in the fluid volume pre and post treatment. And so now we have, instead of the binary either active, inactive, or the ordinal scales between 0 and 4+, we have this continuous measures and a number of different continuous measures that show you whether you're inactive or active. So how can we use this, and how can we actually look at this? So we looked at this in a prospective study of imaging quantification of inflammation, or the IQI study, and we had 2 phases, and I'm going to focus on phase 2 here. So phase 1 was where we correlated automated measures of inflammation to visual acuity and assessed the feasibility of following these patients using that. And then the phase 2 was measuring agreement of inflammatory activity, so looking at clinical exam alone, clinical exam plus imaging, which was considered the gold standard, or a masked reader using the automated imaging alone, and even further than that, a priori setting thresholds for active versus inactive on the automated imaging and seeing how that correlates to the gold standard of clinical exam plus imaging. So this was a prospective observational case series of patients who had at least one eye with active inflammation and were followed over a 6-month period. And at every visit, patients got an OCT of the anterior segment to quantify AC cell. They had an OCT of the macula and an ultra-wide field FA at every time point. And we measured the agreement between those 3. And what we wanted to see was if could a masked reader using the automated software determine if the patient is active or inactive using pre-specified cutoffs. So for fluorescein leakage, AC cell density, and OCT thickness, we pre-specified those numbers. And this was in 25 patients of 50 eyes, 10 men and 15 women who were followed over 81 visits. The vast majority had idiopathic uveitis, but there were some patients with HLA-B27, sarcoid, birdshot, and VKH. And what we found is for a clinical exam alone, compared to the gold standard of a clinician examining them and then looking at imaging afterwards, that the clinical exam alone didn't have great sensitivity for picking up active disease. So the active patients were fine, but it was the ones that were called inactive initially on clinical exam that ended up actually being active when you added the imaging in. So the sensitivity wasn't great, but the specificity is pretty high. But then when you look at the automated assessment has both a high sensitivity and a high specificity. There's one patient who they misclassified in one category and then 12 in the other, but overall, both the sensitivity and specificity, and more importantly, the negative predictive value is very, very high. So that automated assessment can be used in these patients. And so it's both highly sensitive and specific measure of inflammation, and it's a continuous measure. And so what we'd like to do next is assess the risk of vision loss by using these imaging measures and implement it in a clinical trial endpoint. So what I'm next going to talk about is an investigator-initiated study that we did in patients who were being treated with the fluocinolone acetonide implant. And there was very limited imaging data that was available for this because in their phase 3 study, they didn't actually collect and reanalyze the data afterwards. So we looked at this prospectively. So there's just 31 patients who were enrolled at a single institution and were followed over a year. And 29 of those were included that had follow-up. We had a couple patients drop out. But overall, there was 18 females, 11 males, wide age ranges from 23 to 79, and about half of them had bilateral disease and the other half had one eye only. And we looked at the baseline values compared to 3, 6, 9, and 1-year data. And there was a mix of patients between posterior and pan uveitis for the vast majority, with one patient had intermediate uveitis alone. And the diagnoses were quite a few, with the vast majority being idiopathic, and then sarcoid and retinal vasculitis being the next two largest groups. And overall, so for these eyes who were mostly active at baseline, 45% required rescue treatment within a year, but the vast majority of those rescues happened within the first 6 months, and only 7% after the first 6 months. So basically, if you're treated and you get past the first 6 months, you tend to do well. Multiple patients required at least 2 rescues, and the eyes who had worse baseline imaging characteristics were at a higher risk of treatment failure, especially on OCT. But what we see over time is that the central subfield and mid-subfield thicknesses decrease over time, and the leakage area initially very quickly decreases. So it's interesting that how quickly it comes down and actually starts to come back up a little bit. So it says that the disease may be even a little bit more active than we're seeing, and some of this has to do with those recurrences that are occurring. The overall safety data was pretty good. The percentage of eyes who had an IOP increase of greater than 10 from baseline was very low, and the percentage that were on requiring IOP drops was similar. No patients during this one-year study required incisional glaucoma surgery during the study. And so overall, the leakage in OCT thickness tends to decrease with treatment with this long-acting steroid, and patients with active disease at baseline show flares within 6 months for the vast majority, but the degree of inflammation improves and the safety data is in line with what was seen with phase 3 studies. So now we have quantitative measures that we can use to really predict and then model treatment over time, and to use that to develop next is to develop a predictive model of treatment response. So can we predict who is going to respond to one treatment versus another a priori? And can we use automated diagnostics based on imaging metrics alone? And then can we actually then compare this intraocular sampling and the genotype-phenotype data to what we see on imaging? So this is a work of a large group, and so I'd like to thank everyone that's involved. And this is us at our holiday party a couple years ago. Thank you.
Super spreader. Super spreader event.
That was not a super spreader event. Let's first start with some questions for the panelists. And I think there was one justice on the machine for Amani, whether or not you can use the deep capillary plexus between machines, the metrics between machines. So do you have any comment on that?
Yeah, that's a great question. So it turns out you can't just use the machine data. So I didn't tell you this. So we did a lot of, that's a secret sauce. So it turns out all the machines overestimate the deep capillaries when they're ischemic. So when there's deep capillary ischemia, the machines tell you everything's okay because they see noise and they basically give you bad data. So we have to use software to actually clean the data and remove the noise so we can get actual deep capillary data. That's the biggest problem with all the machines right now is that, number one, they don't have the same segmentation algorithms. They don't use the same software. You don't know what thresholding they're using. So there's a lot of problems. So we just use the raw data and analyze it ourselves, unfortunately.
So we're just going to throw away all the software. Awesome. Prithvi, yes, sir.
Yeah, so I had a question because those were some excellent talks this evening. So, Justice, Amani, you're talking about very highly specialized laboratory analyses of these images. And, great talks, and it gets better each time I hear them. What's it going to take to get this into the machines, until we can actually have them and not have to go into your lab? And it just seems like, the machines themselves don't really change. I have the same one now for a couple of years, but this technology is improving. And what's it going to take to get it where we can actually apply it? What's the holdup?
Well, when you look, we're starting to see it in some of the machines. What Dan showed with the home OCT, it is actually integrated into the system. So I think one of the things is a real impetus for the device company to put it in.
Yeah.
Where they have to take it through the FDA clearance aspect, for getting that software approved. And right now, it's not necessarily clear that there's something like anti-VEGF that was a game changer for using OCT. So I think when we have something, let's say for example, risk stratification in dry AMD, and you need something in there to understand who you should be treating, I think all of a sudden those likely start to become available much more quickly. Almost all of these OCT companies have research pathways that are doing similar things to a lot of the research labs that you see, but they haven't necessarily taken that step to put them into the FDA-cleared systems.
Let me flip the question around. Prithvi, how much would you be willing to pay for your next system to have it? Because that's really probably what it takes. I mean, there has to be a customer base for these people to go through, for these companies to go through. I mean, that's we've been unfortunately told that several times that there's no market for measuring anterior chamber cells because it's not a really viable thing, and I continue to say that's incredible because every single trial that seems to go wrong is because inflammation is not measured. So until the customers, us, say we're willing to pay for it or we're willing to have it, I don't think we'll see it. Or it's Peter starting a company that puts it all in the cloud. Rick, yeah.
Let me ask Prithvi a question. If you have an OCT, a big OCT across a lesion, even though you can't see through the thickness of it, you know the curve of the eye is going like this, and all of a sudden you have a lesion this big, and you're back to the curve on this side. Why can't you just measure the height off the OCT?
Yeah, so it's a great question, and there's been great work looking at measuring the thickness exactly of the choroid, not like what you get with an ultrasound, which is like choroid and retina and everything on top. So a couple of the issues is to be able to see that external sclerochoroidal junction. And
But you can impute this line from where you can see it.
so you can definitely estimate.
You want more than 2 millimeters or less than 2 millimeters? I think that would be a pretty accurate.
So I think that's a really good point, and I think sometimes it's just being able to get that bottom point. If it's a wide lesion, you may not be able to get it across a typical line scan, but I think that's an excellent point.
Prithvi, can I ask a question? I thought it was really interesting. I mean, I think Dan would appreciate you found a reason for the green to use Optos.
We'll call it the
Hey, the green is great.
Out of curiosity, was there any difference in location of the lesion in terms of what you would find on the measurements? Because sometimes I feel like there is a differential in terms of that saturation between the two channels. Did you see anything? Did you look at location of lesion and what you found for the measurements?
So I wanted to show you our best stuff, Justice, but I think what we're trying to do is just to kind of prove concept, and we kept it at post-equatorial lesions. Clearly, when we have lesions that are anterior to the equator, it really kind of distorts its appearance. And sometimes you get this like very dark appearance. So we haven't specifically looked at those specifically.
How about amelanotic melanomas?
Getting there. We found that it's the pigmentation that seems to give us that difference, and things like drusen and halo appearance. But we're in process of looking at other lesions like metastatic lesions and hemangiomas, because they're going to have a different color pattern, and that might give us a different appearance. So again, our goal right now is to say, can we have a system that would allow better referral? But I think the ultimate goal is we want the best diagnosis. So I think that's going to be part of the next steps.
Go ahead, Adrian.
Can I ask Amani a question? So I think about the DCP a lot, and it's vulnerable in ischemic maculopathies, not just diabetes, but I look at it in sickle, but also vein occlusions, retinal vein occlusions. Is it vascular, neuronal, some combination of both? Is the DCP kind of the sitting duck and vulnerable because it's in between the inner retinal circulation and the choroid, and just as vulnerable to ischemia and damage?
Yes.
All of
Yeah,
all of the above.
all of the above. But it's probably also because they're the smallest vessels, right? If you think of the vascular tree, they're the narrowest caliber vessels at the bottom of the end arteriolar system. And then you have this funky vortex veins, and I don't know what kind of shear stress is going on in that system where you have collecting venules draining into one venule. I mean, it's bizarre. We don't have that system anywhere else in the body, so it must be under a lot of shear and oxidative stress and all the rest. Yeah. It's great.
But it's got to be more than that, right? Because the vessels are coming off the inner retina. So if you have an inner retinal vessel loss, you by definition will have deep capillary plexus being gone too. So, I mean, every layer adds on itself, and the deeper you get, the more susceptible it is to loss.
For sure. Yeah, if you have inflow problems, yeah.
Hey, Dan, practically speaking, as you do the next DRCR study and such, and we were just talking about, like, I can't imagine trying to get an OCTA, outcome metric if every single software is different in each one? How do you solve that from your your study chair position? Okay, great. We'll move on to the next question. So that says it. No, and also, I mean, is there a short answer?
No.
No, there's
Okay, good.
not. Actually, that's a highly informed no.
Yeah.
When you look at, so we've been collecting OCTAs in a couple of our studies in W, in protocol AA, and basically 40% of the OCTAs are unreadable. They're unusable. I mean, it is that poor. And when we've been pounding on this issue, and then when we were designing a trial to look at non-exudative CNV, MNV, non-exudative CNV, I'll use it there. We kept in talking to arguably two of the better known OCT reading centers in the country. Every 6 months, the software changes. And they would say, oh, well, as long as you have the raw images, we can go back and apply the software. So we believed it for a while. We collected a lot of data, and then we said, oh, now you have this new way of looking at this. Can you apply it to the older images? Oh, no, we can't do that. So it is, I mean, OCTA is, gosh, I'm going to make a really strong statement.
Oh, boy.
It is almost worthless right now from a clinical trials, using it as a marker, as an outcome variable, using it as an outcome variable. It has huge, value potentially to us. You can see a lot of things we didn't know was there. There's a lot of really cool things to look at. Sometimes it's a Rorschach test, right? But from a clinical trials outcome variable standpoint, it's unusable.
So Amani's getting rid of her OCTA device after today. So I got through the first slide, which was questions, and we're going to end there. So we're going to go to a break at this point to maintain and stay on time. We're going to take a 25-minute, how long is the break? 15-minute break. Please visit our exhibitors and
Post on social media.
Post on social media. We're going to come back strong with an incredible second half with some great speakers and end on time. Thank you.